we want to get started with some background for everybody's benefit. But we also have a lot to cover. So I think we will go ahead and get started. We have critical mass, I believe, and seeing a number of friends and colleagues joining. And perhaps in addition to the good afternoon and good morning and good evening, I'll also say Happy New Year. This is actually the second webinar of today and the second webinar that AVAC has had of the year. We began a couple of hours ago with the first of 4 in a series of webinars about cervical cancer, given that January is Cervical Cancer Awareness Month. And it was terrific, as I know this will be as well. We'll also put in the chat later in the call, there are 3 more cervical cancer webinars throughout the month. So I'm delighted to welcome people to the month, to the year, and most of all to this important conversation. As I say, I'm Mitchell Warren, the director of AVAC, and AVAC began now almost 30 years ago, focused on HIV vaccine advocacy, and it is where we started and where we continue so much of our work. And like many of you on the line over the intervening years, in addition to remaining vaccine advocates, we think about other modalities because no one modality will end this pandemic. And many of us have also talked about PrEP over the last 20 years now. And so today's conversation is really a great way to start the year because it reflects some innovation from researchers and communities in a way that I think, as I look out at the field, is one of the greatest examples of thinking creatively, thinking in real time and adapting in even realer time. And you'll hear a bit about that in the midst of research adapting in the midst of COVID, that the PrEPVacc trial really represents a milestone. And you will hear about some results that are, as I think you all know from having heard reports before the end of the year, are disappointing. Those of us who've worked in HIV vaccines are not are never shy of facing that disappointment. That is the process of scientific progress and innovation. And the PrEPVacc team has really demonstrated that creativity and leadership and commitment and resilience in the face of all of that. And you will see that displayed in the course of the next hour or so. And then we hope in a conversation with the PrEPVacc team in the last half hour or so of this call. A few little logistics issues. We are making sure that we'll keep everybody muted throughout this call to keep the line clear. It's being recorded. It and the slides will be available on the website, hopefully later today or tomorrow, as a reference and a resource, because there's a lot you will hear to unpack, not only about what has happened, but what it means for the field going forward. We have a series of 5 presentations, really. 4 will have PowerPoint slides to give you a sense of the story behind PrEPVacc, how it was developed over the last decade, how it was implemented, and some emerging results from the trial. And then very importantly, always at AVAC, we think probably most importantly, a perspective from a community advisory board member about what this trial has meant and why it is such an important study, irrespective of the results. So we were excited to kick that off. I will encourage people to put questions in the chat as we go, and feel free, there's the Q&A function as well as the chat. Please do feel free to use it. We are going to pretty much go through all of the presentations. However, if there are any questions that come up that are very clearly questions of clarification for a presenter, I will probably address those in between speakers. But in general, we hope to move forward quickly and expeditiously and get to conversations. But please do put questions and comments as we go. We're going to start really to help frame this entire conversation with Sheena McCormack, who has been a great friend and mentor to me over many years, and thinking about research and how to do it and how to do it well and how to do it in a meaningful way with communities in all of their diversities. And Sheena has really worked with collaborators that you'll hear later in this call in the design and implementation of this study. And Sheena, you have always been a step ahead in the field. And I think about our PrEP experiences and what you did in the UK that really propelled PrEP forward after the original efficacy trials. And as that was winding down, you were already thinking about the next study and working with partners to create PrEPVacc. So with that, we're going to start with Sheena, who's going to give us an overview of the trial design so that people really understand what the trial was trying to do.
Lovely. Thank you, Mitchell. And thank you so much to AVAC for organising today, and also for providing us with the GPP training, which we're extremely grateful for. So I'm going to go off camera now as I share the slides, just to be, I think, hopefully efficient. Okay. And I think you'll be seeing that full screen now.
That is perfect, Sheena. Take it.
Okay, fantastic. So a little background, it's led by African researchers who you're going to hear from next, based in Entebbe, Uganda, at the MRC-UVRI and LSHTM Uganda Research Unit. And they're supported by 15 partners, institutional partners from Africa, Europe, and the US. So it's a very international group. It builds on long-standing HIV prevention partnerships, which have been developed primarily with European funding, and a key focus on capacity building and transfer. We're over that now, I feel. So EuroVac, TamaVac, and AfroVac, you can see the VAC, those are all vaccine studies, and then the microbicides development program. So the partnership brings together vaccine candidates, key populations, and then know-how in the fields of immunology, social science, and data science. And in 2017, which was our kind of final iteration of the grant that went in, the vaccine candidates had been ready really for a few years for the next step, clinical efficacy testing. So we talk about 3 trials in one, actually 2 vaccine trials, because there are 2 different regimens, each compared to placebo. Shall I just, I don't know if you're seeing that like I am, but that's perhaps better. So one regimen is the DNA HIV PT123, the EuroVac clade C DNA with the AIDS vax, which you'll be familiar with, clades B and E. That had been evaluated as a combination in 4 phase 1/2 trials in the US, Europe, and Uganda, shown to be safe and immunogenic. And the references are in the protocol, which is on our website. And then the MVA CMDR, which is clade A and E, and the CN54 as a clade C GP140 and MPLAL, had been evaluated in Tanzania and Mozambique, admittedly with a different adjuvant, very similar to the MPLA, GLA-AF, in populations that had received, first of all, the HIVIS, the Swedish HIVIS DNA, and been shown to be safe and immunogenic. Now, unfortunately, the HIVIS multiclade DNA was not available for us to take forward, and so we substituted the DNA HIV PT123. And the objectives were to assess the safety and efficacy of these 2 prophylactic HIV vaccine regimens, each of them compared to placebo, preventing acquisition of HIV. And the vaccines were given at weeks 0, 4, 24, 48. At least those were our target weeks. And Eugene will say a little more about that later. And so they were the 3 regimens. We were a little different to previous vaccine studies in terms of the definition of our primary efficacy endpoint, because this required, we only counted people who had completed the first 3 injections and were negative at that point in time. So 2 weeks after the 3rd injection, the time point when we anticipate would be the majority of participants would have peak immune responses, was when the primary vaccine analysis started. And it went to week 74, the visit 15, or indeed beyond that. And for the safety primary endpoint, it was a clinical decision to discontinue injections for an adverse event that was considered related to the product. So we wanted to design this trial to detect a vaccine efficacy of public health relevance. And taking you back to that period in 2016, 2015, 2016, we'd seen 86% reduction in HIV incidence in PrEP trials, indeed in our own trial in PROUD, and near perfect protection when it was taken consistently around condom sex acts in program delivery. So we felt, a vaccine doesn't have to be as good as that, but these vaccines are multiple doses. They are cold chain. They're not just a single product, they're different products. So it really had to be pretty good, because that's quite a lot demanding of public health to implement it in the national campaign. So we set the target efficacy at 70%. And that wasn't unreasonable. The reduction in HIV incidence seen in RV144 in the first 12 months of follow-up was 60%. So we felt that could be achievable. And obviously, if you're targeting a 70% reduction, an observed effect lower than that could still be significant. And it was important for us, because what we will have to do after this was a phase 2b vaccine trial, would be to go to a licensing trial. And we felt, given that this study was being conducted in sexually active adults, it was logical to incorporate PrEP as a study drug to support the vaccine regimen through to that time point of peak responses. But obviously at this stage, PrEP was strongly recommended by WHO, and clearly PrEP was going to be available to our participants as part of standard of prevention throughout. Okay, so we use something called end-stage software that's been developed at MRC CTU initially for cancer trials. It permits multiple arms in the study, multiple stages of looking, and if at any of those stages you see futility for a product, you can change the randomization ratio, so that's adaptive. Indeed, if then something new comes along that's good, you can add that in as a new randomization. Within that software, we put in an assumed incidence of 4 per 100 person years for HIV infections. We assumed a 10% loss to follow-up, because we'd had good retention in the previous trials we'd done in Tanzania and Mozambique. That meant that with this target efficacy of 70% reduction in HIV relative to placebo at the final analysis, we needed 556 participants per group. And to put that into the context of endpoints, that's about 20 endpoints in the placebo group by the end of the trial. So a smaller number than you're used to seeing in other trials. And I'll try to explain on the next slide some of the reasons behind that. So one formal analysis was planned when approximately 7 infections were there in the placebo group. So this is to try and explain here. You see in this table that we've set the efficacy, the target efficacy at 70%. As I said, we've set the incidence at 4. With that particular arrangement, you need 500 per group, and assuming a 10% loss to follow up, it's 556. If you look here at the next level of efficacy at 50%, which is much more like the previous vaccine trials, it's tended to be the common target set to date, and a 4% incidence, you see here you need 894 people. So it goes up from 556 to 894. Whereas it's interesting to see how big an effect the change in efficacy has compared to changing incidence to 3, where it just goes up to 623. So I hope that gets the message across, and you understand why PrEPVacc was smaller than previous studies. So there were 3 trials in one, and the third trial was a PrEP trial. We had considered how PrEP will be integrated, and as I say, we thought, well, sexually active adults having a vaccine, a national vaccine, you will be giving them PrEP to cover the time to peak immune responses. And initially, when we first set out, we were planning to offer Truvada to everybody. But then Discover reported, and you'll remember that was in men and transgender women, and the regulators licensed Descovy for use by men, but not for women. And because we were recruiting a predominantly female population, we took the opportunity to evaluate Descovy in PrEPVacc. Now, that was also, I think, before Gilead had decided to do the Purpose 1 or 2, whichever one it is, where they're looking at lenacapavir, but they're also looking at Descovy and Truvada in that one. So this would complement that study, but the idea came first. And we incorporated the PrEP trial as a second randomization. Now, this is an important point, because in the randomization, it was an offer. This was a vaccine trial, which we had put a second randomization to PrEP in. So people didn't have to take Descovy or Truvada. They didn't have to take PrEP. It was an offer, but the vast majority of our participants did. I think it just 93 real people that went on that actually declined the offer of PrEP. And this went on until they'd had third vaccines, and 2 weeks had followed the visit after the third vaccines for safety. And after that point in time, PrEP was sourced locally. And the local source has evolved over the time that been working in the communities, but currently, and for most of the trial, it's been available in clinic in Durban, the HPRU, the SAMRC clinic in South Africa, and in Muhas in Dar es Salaam in Tanzania. It is available now from several providers in Lusaka, and some of those providers, but not all, provide treatment. So there are quite a few providers that only provide PrEP. And available through donor programs close to the clinic in MMRC and Mbeya in Tanzania. So the objective was to show that the effectiveness of Descovy. Thank you. The aim was to show the effectiveness of Descovy was not unacceptably lower than the effectiveness of Truvada. And of course, it's a challenge because Truvada is really very good when it's used consistently. And so we've known for a long time now, I think definitely even when we were designing the PROUD study, we knew that you needed innovative design and innovative analysis to try and address this issue of very few endpoints. We know the effectiveness of Truvada is broadly aligned to adherence. So I wanted to say a little bit about the adherence data that we're collecting. So we have self-report, and on 5 occasions in the study PrEP period, we asked participants how many days was it since the last sex act without a condom, and then how many tablets did you take in the 2 days before that sex act, and how many tablets did you take in the 2 days after. Now, of course, if sex has taken place within the 2 days of the visit, we couldn't answer that question. But this is the important time for taking PrEP. We also have drug adherence data. We've collected dry blood spot samples to measure drug on 2 occasions during the study PrEP period and every 6 months in the non-study PrEP period. And then when we've had urine kits available, we've tested those in real time and shared the results with the participants. And when we haven't had them available, we've stored the urine in the freezer and then tested retrospectively. And that's 3 occasions in the study PrEP period and every 6 months in the non-study PrEP period. So adherence, when does it matter? We know from previous trials and programs, it's very challenging for people to take PrEP every day. And of course, people aren't at risk every day. They don't have sex every day. So we really aim to ensure that PrEPVacc participants knew the important time to take PrEP was around sex acts without a condom. And Rachel will tell you about the social science insights we've had. They are so valuable, absolutely key to understanding participant behaviors. But in terms of, I'm going to come on to talk about the impact of your assumptions. But here is our table for assumptions that underlie the power in the PrEP part of the study. So we set out to enroll 556 times 3 groups, that's 1,668, and usually we'll explain why the reality is lower than that. We have to remove the participants who declined the offer of PrEP. The original protocol, the plan was to follow up for target weeks of 26 weeks. But again, Eugene will explain we had a delay to vaccines. We allowed the 3rd vaccine to be given up to 40 weeks after enrollment. And that meant that actually people's time on study PrEP was longer. For the counterfactual incidence, we had assumed in the protocol for the vaccine trial, it will be 4%. So we explored values of 3 to 5%. We think that could be an overestimate, and Sheena will give you some insights into this. So we've looked now on the next slide. I'll show you what happens with values of 2 to 3% for the PrEP study. And then in terms of the effectiveness of Truvada and its alignment to adherence, we were thinking that adherence might lie somewhere between 50 and 80%. It looks like in terms of adherence around sex acts anyway without condoms, that could be an underestimate. So we're now looking at values a little bit higher than that. And you see in this next slide the impact of that. So this is the unacceptable, if Descovy was the lower confidence interval suggested it was no better than 50% as effective as Truvada, that would be unacceptable. So that's what that column is. You see if the effectiveness, the adherence in the effectiveness of the efficacy is only 70%. At the lower placebo values, our power is really very low. The lower incidence values, sorry, power is very low. But as the effectiveness of Truvada improves, 80%, 90%, now we're looking at a power that's reasonable, a reasonable probability of being able to show that it's at least 50% as good as Truvada. So acceptable power at these higher levels of adherence to the control group Truvada. So doing 3 trials in one study population is important for people to consider. I think it is, there are less and less populations with higher incidence, and that's a fantastic thing. 2 vaccines and 1 PrEP trial. We were only counting those infections from the time of peak immunity. That was intended to give the vaccines the best chance of demonstrating a biological success with as few endpoints as possible. It was adaptive. We knew we could change the ratio if there was futility in an arm, but also we had the potential to add something new in if that was the direction of travel. Of course, we knew that including PrEP as a study drug, where we expected adherence to be higher, we knew that would increase, it could increase non-study PrEP uptake and persistence, and that would reduce the power in the vaccine trial, but that would be a good result for communities. And so that's offset, it's fine. The assumption of 4 per 100 person years HIV incidence was very uncertain, and Sheena will say more about this. Test, treat, and PrEP were increasing, and for 2 of our study populations, we had less data prior to starting PrEPVacc. And then, as I mentioned, the assumption of 70% adherence was also uncertain. At the time that we actually started and launched the program and the project in 2018, January 2018, locally sourced PrEP was only available for our study populations in 1 location, in Masaka, in Uganda, because at that time in South Africa, it wasn't available to a general population. So I want to just draw this to a close by at least listing here all the partners and giving you a pointer to our website where you'll find the protocol. As I say, it's been led from Africa. Eugene, Sheena, and Rachel are absolutely part of the leadership there. Imperial is the sponsor, and then we've had a contribution at CTU. But we've also got fantastic immunologists helping us with this. We've got all those partners who are running a centre and great laboratories, and then our partners who've brought products to the table. But the most important partners of all are the communities that we've got around the PrEPVacc centres. So Mitchell, that's me done now, and back to you.
Great, Sheena, thank you so much for providing that overview. There's some great questions in the chat. I think some of them actually, including the most recent one about the relationship between PrEP and sex acts, and then with incidence. You discussed some of that, Sheena, I think, and some of it may come out even further in this next presentation. So I think we'll move straight to that, and we'll come back to these if they're not perfectly answered yet. But we'll next turn to Sheila Kasime from the MRC UVRI in Uganda and the LSHTM Uganda Research Unit, who's actually been the PrEPVacc statistician. And I'm excited to hear you, Sheila, as ever. And particularly, as Sheena said, it took innovative trial design, but also an innovation to thinking about analysis of what the study would uncover. So delighted to turn it over to you.
Great. Thank you, Mitchell. Thank you, Sheena. I think I'll just get started with my presentation. I wasn't sure if there was a question in there. I lost you for a minute.
There were some questions. I think actually Sheena might have even addressed some of it, but I think go ahead and present, and we'll come back to this after, just so we stay on time.
Great. Great. Yes, thank you all so much for joining us today. Good afternoon, good evening, good morning. Yeah, my name is Sheila Kansim. I'm a statistician on the PrEPVacc team. There are several other statisticians, just want to acknowledge them. And for today, I'll just be giving an overview of the PrEPVacc analysis plan, a brief overview of the analysis plan. Yeah, so the trial, as Sheena mentioned, had 2 main objectives. One was to assess the safety and the efficacy of 2 HIV prophylactic vaccine regimens, comparing each of those regimens to the placebo arm. And we also aim to assess the safety and the effectiveness of Descovy in comparison to Truvada. We were assessing whether Descovy was non-inferior to Truvada at preventing HIV incidence in the context of background HIV incidence. Yeah, so this is the study schema. We had 2 active vaccine arms and then 1 placebo arm. And participants could receive vaccinations at 4 time points in the trial. That was at visit 2, at visit 4, visit 8, and visit 12. The weeks were already mentioned by Sheena, but as she also mentioned, these varied once due to certain challenges that Eugene will go into detail. But the target weeks for vaccine administration were week 0, week 4, week 24, and week 48. So up to visit 9, participants were expected to not have yet reached peak immunogenicity and protection from the vaccine. So the time period all the way up to visit 9 was used to conduct the PrEP component of the trial. So when I refer to the PrEP trial component, I'll be referring to visits 2 through 9. At which participants were on Descovy or Truvada. And beyond visit 9, we expected the participants had reached peak immunogenicity or peak protection from the vaccines. And for the vaccine component of what I may refer to as the vaccine component of the trial, we were interested in assessing whether the active vaccine regimens were superior to the placebo arm. That was beyond visit 9. So the primary vaccine efficacy outcome was HIV acquisition by a participant who completed their first 3 immunizations and was HIV negative 2 weeks after the 3rd. And they needed to have at least 1 follow-up assessment thereafter. Participants could stay in the trial all the way until the end of the trial or until they seroconverted or were lost to follow up. For the main vaccine efficacy analysis, we intend to report hazard ratios estimated using the Cox proportional hazards regression model, which will be adjusted for site and sex. And the vaccine efficacy will be estimated as 1 minus the hazard ratio for each active arm in comparison to placebo. We intend to report p-values, 95% confidence intervals for the vaccine efficacy estimates. And we also intend to conduct supplementary analysis where follow-up will be truncated at visit 15. That is target week 74, which should be about 48 weeks after visit 9. That was after the start of the vaccine sort of component of the trial. And we'll also conduct supplementary analysis where follow-up will be expanded all the way from week 0. Yeah, so that's it for the vaccine efficacy analysis plan. While the trial was going on, there were routine biannual IDMC reviews of the data. They looked at the safety and the incidence data by treatment arm. And additionally, there was 1 formal planned interim analysis. And this interim analysis would occur when we would have 7 infections in the placebo arm. And if at that time point, we had the number of infections in one or both of the active arms was equal to or it exceeded the number of infections in the placebo arm, the IDMC could recommend stopping of the trial. And they could recommend stopping of further enrollments and vaccinations to the relevant arms after they reviewed additional analysis, such as the conditional power of the trial. So the trial could have continued as planned or stopped at that interim analysis. And for the vaccine analysis, the safety and the secondary outcomes, the primary safety outcome, as Sheena had mentioned, was a clinical decision to discontinue the vaccine regimen for an AE considered related to product. We also are looking at other secondary outcomes, such as grade 3 and above solicited AEs that lasted more than 72 hours, grade 3 and above lab AEs, AEs leading to discontinuation or interruption of the vaccine schedule, serious adverse events, other clinical and lab AEs as well. And these outcomes would be compared across the trial vaccine arms using descriptive analysis and would report proportions and rates as appropriate with 95% confidence intervals. Yes, then for the primary PrEP effectiveness analysis, we were looking at the primary outcome was HIV acquisition by a participant before visit 9. And these participants had to be HIV negative at enrollment to be included in this analysis and randomized to either Truvada or Descovy and dispensed drug. So it was sort of a modified intention to treat analysis, to the modified intention to treat analysis. And for the PrEP component, we intend to report the number and the rate of infections presenting each by PrEP arm, the rate difference and the rate ratio with 95% confidence intervals. But the main outcome for the PrEP effectiveness analysis, which informed the powering of the trial, was the averted infections ratio, which informed the powering of the PrEP component of the trial, was the averted infections ratio. And this is the formula of the averted infections ratio. It compares the rate in the Descovy arm to the rate in a Truvada arm. This is just an example, so kindly ignore this. It compares the rate in the Descovy arm and the rate in the Truvada arm, but it also incorporates a rate in a placebo arm. But for the PrEPVacc trial, all our participants were randomized to a form of PrEP, and to be included in the PrEP trial, they had to accept at least one dispensing of PrEP. So we didn't have a placebo arm. And this rate in the placebo arm, it's hypothetical, it's counterfactual, it's estimated. In a way, it's what would the incidence rate have been if these participants who received PrEP did not receive PrEP? So it's estimated. And in a few slides, I'll explain how we intend to estimate this rate. But yeah, that's the averted infections ratio. Then to inform more on the PrEP effectiveness in our trials, we also intend to conduct supplementary analysis. The safety and secondary PrEP outcomes. The primary safety outcome for the PrEP trial was a clinical decision to discontinue the PrEP regimen for an AE related to product. And secondary outcomes included AEs leading to discontinuation or interruption, SAEs, and other secondary outcomes, genotypic resistance at HIV seroconversions and adherence to PrEP. Secondary outcomes, not safety. Sorry. So all these outcomes will be compared across the PrEP arms using descriptive analysis, showing number and proportion / rate as appropriate with 95% confidence intervals. Yes, so I had mentioned that we would incorporate this hypothetical placebo incidence rate. So in the statistical analysis plan, we indicated that the averted infections ratio will incorporate this placebo incidence, and we would estimate this hypothetical placebo incidence in a number of ways. One, we could use data from a pre-trial registration cohort, and we could use statistical modeling to adjust for calendar time trends and differences between the pre-trial registration cohort and the trial in terms of important predictors of HIV incidence. So we got data from this pre-trial registration cohort, which I'm going to provide more information on. We use the incidence data from that, use statistical modeling with that data, create a model, then get data from the PrEP trial component of the trial, feed it in that model, and predict a counterfactual incidence. So that's one of the approaches, and we'll be able to see results from that approach today. The other way we could estimate this hypothetical placebo incidence is we could use data from the follow-up from the follow-up of trial participants during the vaccine study after visit 9. So after visit 9, participants were encouraged to stay on PrEP, but it was really their choice to stay on PrEP or not to stay on PrEP. But that had then gone into the vaccine component of the trial. And we can use the incidence data from that period, mostly that among participants who opted not to stay on PrEP, to kind of inform us of what could the counterfactual have been if we hadn't even given them PrEP in the PrEP trial component. It's informative as well, though we likely would have to exclude participants who opted to take non-trial PrEP. But also worth mentioning is that if the trial, if we at analysis we found that the vaccine efficacy is null, then all the data from all the vaccine arms, not just the placebo arm, from all the vaccine arms could contribute to this counterfactual estimate. If the vaccine arms had some efficacy, we would likely not be able to just use the data from those arms directly to inform this counterfactual, but that would only be informed once we find that vaccine efficacy is null. Just to mention, the final analysis have not yet been conducted. So you won't be seeing results today, but just the analysis plans in the progress of the trial. Yeah, so the registration cohort, so prior to the conduct of the trial, there was a pre-trial registration cohort in the 18 months leading up to the trial, and while we were setting up the sites to conduct the trial, but volunteers were encouraged, volunteers aged 18 to 45 years, were encouraged to join a registration cohort where they were assessed on a quarterly basis. And during that time, they were encouraged to take a PrEP and referred for PrEP at locally available sources. And during that time, we collected the HIV incidence data, which we're going to see on the next slide, and that data would kind of inform us on what the incidence was if we hadn't given the participants PrEP. So this was the HIV incidence we observed in the registration cohort. We observed an overall incidence of about 2.9 per 100 person years. However, one thing was very clear, it seemed to drop over calendar period. There was about a 38% drop with every additional calendar year. And remember, this was a pre-trial registration cohort. So the cohort largely occurred prior to the trial. And the trial started around December 2020, so around here. And most of the data collected in the cohort was prior to that. So we almost have to extrapolate from the cohort to inform the trial. One, this drop in incidence over calendar period was quite drastic, but also you'll recall 2020 and 2021 had a lot of COVID disruptions, which would have affected incidence in communities and affected our retention of participants. It affected study attendance in the registration cohort. So we are not sure whether the drastic drop we were seeing was a genuine drop or it was driven by those lockdowns and disruptions. And also once the trial would start, for example, in December 2021, once a study site would start recruiting to the trial, follow-up in the cohort got shorter and shorter, and we ended up having minimal overlap, as I'll show on the next slide, between the cohort and the trial. So we almost have to extrapolate this trend to inform the trial. So it's quite challenging to use the cohort data, as you can see. Yeah, so this was the registration cohort and the trial data. We have to extrapolate in calendar period. Yes, we're adjusting for other participant characteristics, but this extrapolation is quite challenging as well. So one other approach to which we can estimate this counterfactual incidence is we can use adherence data. So in the SAP, we indicated that we'd explore the possibility of deriving the averted infections ratio using adherence data. In a sense, you'd look at, okay, we've observed an incidence rate of this much in the Truvada arm, but we know the adherence of Truvada in our trial, and we know the expected effectiveness of Truvada. So we would be able to work out the background incidence that would have happened if those participants hadn't taken Truvada, in a way to say, but it's also not a precise approach. It's a bit imprecise, but we will attempt to use this approach as well. We intend to use this approach as well. Adherence data, as we mentioned, we have some self-report data on adherence around the 6 acts. We have urine test data, but it was challenged, and in some cases we had to store urines for testing later on in time, which we hadn't intended, and Sheena can provide more details on that, but the urine test data is affected. But we have the self-report data on adherence around 6 acts, and we also have dry blood spots data. We had 600 tests which were conducted at visit 6, which will cover about 42% of the trial population. And we also have 100 tests at visit 9, which will inform us of how reliable how well visit 6 kind of predicted overall adherence across the trial. So we have dry blood spot data as well. And we have this adherence efficacy approach to look forward to. So the sensitivity analysis, making different assumptions on the calendar period effect, predicted varying counterfactual placebo HIV incidence rate. So this is referring to just using the cohort data, you almost have to make assumptions about the calendar period effect during the PrEP trial. So beyond the cohort, you have to extrapolate. And depending on what assumptions you make about the calendar period effect, you can reach a different estimate. In our case, this ranged from 1.2 to as high as 5.1. And one may argue that some assumptions are more valid than others, and the challenge with that is it then becomes subjective. One statistician may find some assumptions more valid than another statistician. So it becomes quite challenging to use the registration cohort data. But we do have the post-PrEP trial component data that we mentioned. And the great thing about that data is we expect it to overlap more in calendar period than the registration cohort. But at least you'd have more overlap with the PrEP trial. So it would be more reliable, and the populations would be quite similar, more similar. And we also have the adherence data that we mentioned as well, the dry blood spot and the self-report data, which will be quite useful. At the moment, discussions on how the data from the various counterfactual estimation approaches will be synthesized are ongoing, and it's all very interesting. Yeah, thank you all so much. I think that's where my presentation ends, and I'll hand over to Eugene to give us more detail on that trial and the registration cohorts. Yeah. Thank you.
Fantastic. Sheila, thank you so very much. There are questions that came just before you started from Andrew Abassa about the incidence and what was estimated and what was actually seen, and it picks up a bit on Charles's question about incidence and the variations. And perhaps both Sheila and Sheena, happy to have you comment on that or prepare their response now, or if you want, about the variation of what was predicted versus what you observed.
Sheila, do you want to say, or shall I start? So Andrew, because I saw that question and I was going to respond, Andrew, to say that I think we didn't know because a PrEP was only available as a locally sourced drug in one centre when we started the registration cohort, or were planning that in 2018. We really didn't know, and so we needed to take advantage of the registration cohort. And I don't remember today. I think, Eugene, you don't have that in your slides, but the uptake we saw in the registration cohort overall, I think, was in the order of 7%. I think that the best that we did was we managed to get 20% of participants in Masaka to start, but then they didn't persist with it in the registration cohort. And so we kind of wondered if, when you offer PrEP as a study drug, it might be perceived differently, to when you offer it in a program, because often certainly reported adherence, but even drug adherence in the PrEP trials like 084 and preceding trials has been higher than we see in the programs in terms of people coming back for more drug. And so it is different. I think participants are really good at perhaps sometimes doing things for the study team, and then when you're asking them to do it for themselves, it's a different matter. So the answer is to your question, yes, I think we feared all along that 4 per 100 person years was going to be an overestimate of the actual background incidence, but we genuinely didn't know how much of an overestimate it would be.
Super helpful. And maybe it will come even back to this after the other presentations, because I think Eugene will be touching on some of these results. And so perhaps we'll go to him, and again, keeping track of the questions, keep them coming. But I think we'll now shift to Eugene Ruzigira, who is actually the PrEPVacc study director, also based in Uganda at the Uganda Virus Research Institute MRC program, and delighted, Eugene, to turn it over to you to give us a sense of the implementation of the trial and some of the early data emerging.
Thank you so much, Micho, and hi everyone. I'll straight away share my slides and start the presentation. Okay, so I'm going to give an overview of the trial implementation and a little bit of baseline data. Just a reminder, these are the study populations. So we worked in sites in Uganda, in Masaka, and there we recruited female sex workers and people living in fishing communities in Masaka, around the shores of Lake Victoria. And then in Dar es Salaam, we had bar workers and female sex workers, and then female bar workers in Mbeya, Tanzania, and the general and key populations in Maputo, Mozambique, and then the general population in Durban, South Africa. So Sheila has talked about the registration cohort. It was a prospective longitudinal observational study, and the objective was to prepare a population of HIV-negative individuals at risk of acquiring HIV for possible participation in the PrEPVacc trial. We targeted to have an HIV incidence threshold of 2 per 100 person years in order for a site to proceed to the trial, and I'll talk about that a little bit later. So an overview of the registration cohort, we recruited just over 4,000 participants. We started in 2018 at Masaka, and the last site I think to start was Veoram in Durban. And as you can see in the last column, Masaka proceeded to the trial, The site Phoenix in Durban did not proceed. It was closed in 2019, and we transitioned the registration cohort in Durban to another site, Verulam, which had the infrastructure required to support the trial. Mbeya and Dar es Salaam in Tanzania continued to the trial. And then in Maputo, Mozambique, we closed the cohort in 2021 due to low HIV incidence, but also because of COVID-19 disruptions. So we had 4 sites proceeding to the trial. So the trial successfully opened at the 4 sites despite the COVID-19 disruptions. And I've taken some pictures from the website, the PrEPVacc website, which we posted as we started at each of the sites. So that was between December 2020 and September 2021. I think some of these challenges have been alluded to by Sheena and Sheila. We obviously lost the Maputo site. The HIV incidence at that site was lower than the agreed to have per 100 person years in order for us to proceed to the trial. This was good for the community, obviously, but it meant that we had 1 less clinical research center in the trial, and therefore that the other centers had to take on extra numbers. Then we had a delayed start. COVID-19 slowed everything down, so enrollment did not start until December 2020. We had hoped to start much earlier than that. And it was really slow. The recruitment was slow despite the thousands of participants we had in the cohort at that point. And then once we started, we had a number of times that vaccinations had to be paused. In May 2021 and April 2022, we had to pause all the 3rd and 4th vaccines. You remember we had 4 vaccination time points. And this was to allow for regulatory reviews of IP stability data. Now, because of the disruptions, these pauses and the COVID-19 disruptions, it was decided to adapt the trial to fully enroll, to be able to meet the target of 556 participants per arm for at least one of the combination regimens. So we stopped enrolling to one of the regimens and continued with enrollment to the other regimen in order to really achieve the sample size at least for that one regimen. And then we had, of course, disruption of supply chains. I think almost everyone on this call might have experienced that if you're involved in research. And some of this actually continues. So a little bit of an overview of the trial. So we screened 2,242 participants, enrolled 1,513. But among those enrolled, 8 did not receive, opted not to receive investigational product. So those who received the first vaccine were 1,505. However, we had 1 individual who enrolled twice. He disguised and enrolled twice, so it meant he received vaccinations twice. We found out, and later his data was merged into one ID. So that effectively means 1,504 participants received the first vaccination. And then this table shows a little bit of the baseline characteristics by center of the participants. So we did recruit the majority of participants from the registration cohort, so it's about 61%. But due to COVID, as I've mentioned, we had to open and recruit outside of the cohort somewhere, I think, in the last 1 to 2 years. And then the median age, as you can see, is 25. So it was a young cohort. It was majority female, 87%, and we had 2 sites, Mbeya and Dar es Salaam, that recruited only female participants. When we look at the risk factors for HIV infection, we've taken out 2 here. So we looked at persons having any STI at baseline, and as you can see, 26% had at least one STI at baseline. And then we looked at condomless sex partners in the last 3 months. So about 70% reported having condomless sex with at least 3 partners or more, with 3 people or more. And I think Sheena has already alluded to this. PrEP use was very, very low. Only about 4% had ever used PrEP at baseline. And then this table gives a summary of the vaccinations by center. So like I mentioned, 1,504 received the first vaccine. Then that dropped to 1,446 for the second vaccine, 1,314 for the third vaccine. I think Sheena might have mentioned that the primary vaccine analysis will consider participants who received all the 3 vaccinations. So this is our number here. And then 1,016 received the 4th vaccine. And this data is from the 2nd of October. So we're using the extract of 2nd October 2023. And then there's been some discussion about PrEP, and I'll give some more detail here. So we look at study PrEP by center, and we've decided to look at study PrEP not taken, so since last visit. And when you look at this, we have about 12% of participants reporting not have taken PrEP since their last visit. And when you look here, I think the striking result is in Masaka, is where we had many people reporting not have taken PrEP when you compare to the other sites. Then when you look at PrEP not taken before the last condomless sex, again, in Masaka, the figure is high, 46%, but at the other sites, particularly in Mbeya and Dar es Salaam, fewer people reported not taking PrEP around condomless sex. PrEP was offered at visits 2, 4, and 7, and if required at other visits, through to visit 9, which approximately is week 26, like Sheena explained. But we had some people taking PrEP up to 40 weeks. And then when we look at uptake of PrEP after the PrEP component of the trial has ended, which should be visit 9, we looked at visit 12. So this is about 6 months after the PrEP component of the trial has ended. And we definitely referred participants to receive PrEP at PrEP providers in Masaka and Mbeya. And at Dar es Salaam and Veoram, PrEP is offered in the research clinic itself. But as you can see, few people took up this offer. Only 3% in Masaka, 4% in Mbeya. Dar es Salaam, 27%, and this is our highest, and 7% in Veoram. So overall, only 8% of participants continued to take PrEP. And Rachel, I think, will talk about this more in her presentation. So I'll now give a summary of the safety data. So we have a trial safety group that reviews adverse event listings twice a month by center. When we look at notable events other than pregnancy and social harms, we had 0 severe grade 3 reactions lasting for more than 72 hours. Then when we look at grade 3 laboratory events that were confirmed on repeat testing, we had 5 of those, but none of them was related to IP. And then we had adverse events leading to clinical decision to discontinue vaccines. We had 3 here. One of them was syncope, the other one was eye inflammation and thrombocytopenia. And then we did not have any adverse events leading to a clinical decision to discontinue PrEP. We had 24 serious adverse events. One was considered related to IP, and that was the syncope that occurred within an hour of administering injections. We had 3 fatalities. These were post-abortion, related post-abortion hemorrhage, alcoholic liver disease, and then renal cancer. And then we have 20 others, most commonly injury or poisoning, and those related to pregnancy and childbirth. We had 23 participant pregnancies within 18 weeks of the vaccine or while taking Descovy. We also monitored social harms throughout the trial and continue to do so. So far, we have 27 moderate to severe harms. All of them are from the East African sites. Mostly, these are partners finding PrEP and assuming it was for treating HIV. So partners of the participants. We had 3 significant social harms reported as notable events. One was a participant who was unable to travel to another country for work due to a vaccine-induced seropositivity in the test conducted by the recruitment agency. The recruitment agency did not accept the participant's offer to do the test at the clinical research center. The participant in the other one, who was getting married, went for an HIV testing with her partner and was found to be reactive, but actually uninfected in the HIV testing algorithm. So another visible case, and her partner postponed the wedding until the test is no longer reactive. Then the third was a participant who was beaten by her partner and shunned by her community after a false allegation of transmitting HIV to her partner. She's actually HIV uninfected and her partner is positive, but the partner just assumed he got the HIV from her. So that's a summary of the social harms. So as mentioned by Sheila, the IDMC has been reviewing the data every 6 months. On 9th November 2023, the IDMC met and recommended that injections stop, but the PrEP trial continue. We've already provided this information. We announced it at a recent conference, the CASA conference in Harare. The primary reason for this recommendation was futility. That is little or no chance of demonstrating effectiveness. Injections were paused from the 10th of November 2023. And the trial steering committee met with the trial team and the sponsor on the 22nd and accepted the IDMC recommendations. And the injections were therefore discontinued. So what's the impact of this on the trial? Participants, community advisory boards, and community working groups and national authorities have been informed of this change. Enrollment was already complete, and there were only 10 participants who had yet to enter the primary vaccine analysis, that is completing the 3rd vaccination time point. Follow-up for safety and HIV testing continues, and this will continue for 6 months, approximately 24 weeks after the last injections. This will end in April of this year. The study team and participants will remain blind to allocation and results until the study database is locked. Participants will be called and informed about vaccine-induced seropositivity status and provision of an ongoing HIV testing service at the clinical research centers. And although the PrEP trial will finish in January this month, at the latest, results will follow the vaccine trial results. So yeah, we don't have results share yet. In conclusion, the registration cohort informed which centers joined the trial and their targets. COVID-19 was very disruptive, and having an adaptive design, as explained by Sheena, helped us to achieve the target sample size for one of the vaccine trial arms, because we were able to stop enrollment in one arm and continue with the other. And then significant social harm, although infrequent, was seen with the vaccine-induced seropositivity, and it will be critical to provide testing and support beyond the trial to participants who have this. And although including a PrEP trial with 2 vaccine trials was confusing for the communities initially, centers overcame this, and it was really an efficient design that ensured the use of minimum number of participants. And then PrEP awareness was raised in all communities. Like I mentioned, there was very low awareness or prior use of PrEP at baseline, but we observed familiar challenges for oral PrEP, including stigma and economic vulnerability, often posing greater risk than the perceived benefits. My colleague Rachel will go a little bit in detail about this and provide some insights from the qualitative component of the trial. Thank you so much.
Eugene, thank you so very much for that incredible in-depth review. Before we move to Rachel, which I do want to do really quickly, there's some great questions in the chat, and I want to make sure we get to some of them. I think the issue of vaccine-induced seropositivity and the issues you highlighted are really quite important. And there was this last question from Morsida Chowdhury about how long it takes for that VISP to pass. And I wonder if you have any sense of that that you can update us on.
So unfortunately, I can't give a figure. So it can last many years. VISP can last really long. And in some people, it disappears in a few months, a few years. Yeah.
Okay.
So it's something that we need to keep track of. Yeah.
Absolutely, and this is not for those on the line and who have been involved in vaccine research for many years now. This is not unique to the PrEPVacc trial or to the PrEPVacc vaccine regimens. This has been seen in many, if not all, of the trials to date, and obviously a very large issue. And Eugene, maybe I'll also just take advantage of you being here on camera right now. And Charles Gonzalez asks about the fact that so few individuals continuing PrEP after the study closed, and did the small number of those who remain, did it correlate at all with the dried blood spot data that you collected?
So we haven't analyzed the DBS data yet. Yeah.
Great. And maybe both for you and Sheena, because a question was asked earlier related to that about PrEP, and Sheena, you described back in the design mode about the first aspect, and Sheila too in the statistical plan, that there was the TDF, FTC, and FTAF in the trial, and then the PrEP at offer in different ways at sites after that period. And someone else, I think it was Olivia Nakanwagi, I hope I didn't mispronounce it too badly, Olivia, asking about why it was optional to continue. And I think it's really important maybe to make sure people understand about PrEP always being an option. But if you want to just clarify that a bit.
I mean, it was an option as a trial drug, an option to take any drug, but also obviously, unlike a vaccine or an injection in a way where you that's also optional. It's all optional, but generally speaking, you're with a pill you take away, it's your choice what you do with it once you've taken it away. But I just wanted to clarify, because that snapshot that Eugene showed you on the adherence, Eugene, that was taken, wasn't it, from the 2nd of October extract. And we know we look at these reports twice a month, basically. Sheila produces these reports, and Verulam was a little behind in their data entry in October, and they've caught up now. So actually that's an underestimate of the PrEP taken, particularly at Verulam, and therefore overall. But yeah, no, I think there honestly is a difference. It would seem, when you're actually presenting something as part of a study, I think really participants, they want perhaps, and we know telling you they're taking a drug might not mean they are taking the drug, but they do want to do well for the study. And it is perhaps a different balance in their head. And I imagine Rachel will pick this up about why they choose to take it for themselves.
Yeah. No, Sheena, thank you. Okay.
I was only just going to quickly say about the VISP, because it was something that Jonathan Weber had commented on, that when we do have the data sort of unblinded, we might be able to model the change in the response to the ELISA and give a better prediction on the disappearance of VISP.
Great. Sheena, thank you. And Eugene, thank you again. And your previous point, Sheena, was the perfect segue into Rachel's presentation. And I'm delighted to welcome Rachel Kawuma to present next, who's been the lead social scientist on this study. And I think it's so important and really great credit to the PrEPVacc team and to the funders that embedded the social science research agenda into PrEPVacc as a core component. Doesn't happen in every study, but I think you all have demonstrated how critical it is. So Rachel, over to you.
Thank you, Mitchell. And yeah, we are very grateful that we were given an opportunity to embed the social science in the trial. So I'm quickly going to share my slides. I hope everybody can see them. Yeah, just to say thank you to all of you for making time to join this presentation. I'm going to present this on behalf of the social science team in the trial. So we had objectives, which I am going to summarize very quickly. And the first one was to investigate the acceptability of PrEP, but also the vaccines in the trial. We also wanted to understand adherence to PrEP, particularly Descovy, which was new to the trial populations, as Sheena has explained. And then we also wanted to provide insights into comparisons of PrEP. And we were looking at what participants thought about effectiveness and acceptability of both Descovy and Truvada. And then the other objectives that we looked at were to understand perceptions and experiences with risk for HIV infection among the trial participants, to explore knowledge of and attitudes towards the trial, the vaccines and PrEP in the general population around the trial, and then to document experiences of some of our staff. So I will explain how we did that, but we mainly had conversations with the community teams and the counseling teams. So this was a qualitative, we mainly used qualitative methods of inquiry, and this was our study design. All the participating sites in the trial, which were 4, took part in the social science component as well. And 3 repeat in-depth interviews were conducted with at least 10% of the participants in sites that recruited less than 300, and that was only MOHAS. But the other sites recruited more than 300 participants. So we intentionally included 30 participants because we felt of circulation and the big numbers. These were sites recruiting over 500 participants. And in terms of sampling, we included equal numbers of those who are on Descovy and those on Truvada. We also considered the age groups, the gender, and then we also looked at their adherence behavior. And this adherence behavior, we looked at it in, we worked with the counselors and the nursing teams that were giving out the PrEP. And so we looked at the self-report data and the urine test reports to just look out for people who are adhering very well on PrEP, those who are not adhering very well, and then we also looked at a subset of those who refused to take up PrEP. In addition, we conducted some focus group discussions with participants in the trial who are not taking part in the IDIs, and we did debriefs with the trial staff, as I earlier mentioned, that we talked regularly with community and counseling teams to just understand their experiences in the trial. Okay, my slides want to move. Okay, there we go. Just to mention that we collected quite a lot of data, almost 400 IDIs and over 15 FGDs. So we are really at preliminary analysis of our data. But today I can share some general insights that we are seeing from the qualitative data. Generally, the trial design and randomization in the study was understood quite well. From Sheena's presentation, the trial was 3-in-1, so 2 vaccines and PrEP. But our participants generally discussed this in terms of 2-in-1. So for them, they will talk about participating in a trial which has PrEP and has vaccines. Then the other thing that we noted was participants found vaccination much easier than taking PrEP. And I think this is related to the fact that with vaccination, they experienced very few side effects, most of which lasted for very few days, compared to PrEP effects, some of them that took longer. And then there was preference for an injectable form of prevention related to the above point I've said, compared to the oral PrEP pills. But also the women in the trial found some methods of contraception an inconvenience, because remember, they were encouraged to stay on long-term methods of contraception. The other thing we found around PrEP was PrEP uptake and adherence varied across sites, but also within the same sites, it also varied across compared to individuals as they assess their own risk to HIV. If you reflect on the previous presentation from Dr. Eugene, you notice that some sites in terms of adherence to PrEP did not very well compared to the others. But in the qualitative data, the one main motivation for people to really take PrEP, we noted, was their perception of risk. So those who felt they were at risk for HIV, they continued their PrEP even after the study period. There are so many barriers to taking PrEP, and these have been documented elsewhere, ranging from the pill itself, taking the pill daily, through to perceived stigma, and well, the fear of being seen taking PrEP. So many factors, as has been documented in other studies elsewhere. So in terms of knowledge, we also conducted focus groups with members of communities around the trial, as I noted. And we noted that in the communities around the trial, there was limited knowledge about PrEP. And with our participants, it was limited initially, but over time, remember I said we did repeat interviews, and this was at the beginning of the trial, 6 months later, and then a year later with our participants. So with the participants, their knowledge of PrEP increased as they continued participating in the trial, compared to members in the communities where PrEP knowledge was really low. I also want to talk about an insight into the Descovy pill, which was very new into these trial settings. So our participants felt it was a smaller pill, so they liked it, and so they found it easy to swallow compared to Truvada. And then they felt that Descovy appearance is different if you sort of compare it to the Truvada, which looks like ARVs. So our participants felt confident and they liked the Descovy pill, because they felt it was this, it attracts this suspicion from people as they take it. And then also they saw fewer side effects with taking Descovy compared to Truvada, which they related with quite a lot of side effects like increasing appetite, tiredness, and so many others. And then we talked about uptake of non-study PrEP. So sites like Masaka and Mbeya referred participants after the 26 weeks in the trial. So we also talked to our participants what they felt about going to the other sites to take up PrEP. But if you reflect on the presentation that came before mine, very few people went to take on PrEP after the study period. And so some of the reasons they gave for not taking up PrEP, quite a lot of them were tired of taking the PrEP. In fact, most of them thought it was a trial requirement. And since they are now not required to take it anymore, they felt they needed to take a break. But there was a lot of perceived stigma. Many said they feared being seen at centers because this would cause suspicion that they are infected with HIV. In Masaka, for example, most of the PrEP is given in centers where there is art. So people going to the same centers was an inconvenience on their part, but also raised structural factors, barriers such as the attitude of healthcare workers, the long waiting time, and also opposition from partners are some of the reasons why they did not take up non-study PrEP. So I want to summarize so far what we are seeing in the qualitative data in 4 points. Generally, the participants preferred an injectable form of PrEP compared to taking daily oral pills. And that I will speak to that in relation to bullet 3, while we noted that they welcomed Descovy because of being small and the less side effects compared to the Truvada pills. But nonetheless, we noted that non-adherence was in both cases where regardless of which pill the participants were taking, and they related this to the fact that they are both pills. The main motivation, as I mentioned earlier, for those who persisted taking PrEP was their own self-evaluation of being at risk. But also we noted that there is more messaging around PrEP in communities in the trial. So we need to increase, there was more messaging around PrEP in the trial. So we need to increase our messaging of PrEP even in communities outside of the trial. So I would like to acknowledge all the social scientists at the different sites. We were guided and led by Professor Janet, who was the co-PI. And also to acknowledge all our funders listed on this slide. The Gilead funded the social science component of this trial, and we are very, very grateful for that. And also to acknowledge all the people who took place in the trial, the different sites and our sponsors. Thank you very much. I'll end at that.
Great, Rachel, thank you so very much. That was a terrific overview. There are questions here. We're going to come back to you in just a minute. There was a great question from Ida Justa from South Africa that I know, Sheena, you addressed, but I thought it was a perfect opportunity to bring in our final presenter, and Koliswa Namvungu from the Verulam site, which you heard, the community working group, and the role of communities, community engagement, and the commitment to good participatory practices throughout the trial really were terrific. And Ida's question in the chat, for those who may not be seeing it on their phones or other devices, asked about how to communicate this very complex trial, given that it's looking at both vaccines and PrEP. Sheena gave a great answer here, but I wonder, before we open it up to all of the questions, if Koliswa, you want to say a word or two about the perspective from the community and your involvement as a community working group member, and how the trial's been communicated out so far and the work still ahead to communicate the ways forward.
Good evening, everyone. It's evening in SA.
Good evening indeed.
Thank you for an opportunity to be part of this forum. Thanks to everyone with the presentation. They are well presented. As part of the working group, we really appreciate all the information that is being brought to us so that we can be able to disseminate the information to the community about the misconception about the PrEP and the HIV and all so that we can be able to cascade the information to the community about the myths about people that are taking the vaccine. We have worked well, and also whatever that was happening, we're very much informed so that we can be able to communicate with the community so that they are well aware of what is it that is happening. And even though we are still waiting for the formal results, but they must not feel bad that we have not yet reached a conclusion about whether the vaccine is going to be effective or not. However, we really appreciate the information that is being cascaded by everyone regarding the vaccine trial. Thank you so much.
Great. Koliswa, thank you so much. And I want to really applaud you and the community working groups at each of the site for that deep engagement throughout the trial. I'm happy to have any and all of the presenters. Please join me on camera if you can, if your bandwidth allows. We have some time, and not as much as we would like, but we've taken some questions as we've gone. And I'll also welcome anyone to come off the line and off mute to ask questions. But I want to make sure we get to a couple of these really important ones. And perhaps, and again, I'll leave it to all of you to decide who to jump in, hopefully keeping the answers as brief as possible. But this very last question from Jasmine Rename asking about why in East Africa, and this is not the only study that focused in East and Southern Africa, comes up all the time. Why is the study, why are studies so often done in that region? I wonder if any one of you wants to explain the rationale behind that. Don't be shy.
Sheena, yeah, I think I can start from my side. For one, it should be, we still have high rates of HIV incidence in those settings, so they make the trials sort of easier to conduct realistically, but those are the populations that stand to benefit the most if we find interventions that work. So yeah, Sheena, or you can comment as well.
I was going to leave to Eugene, but yeah, I think you put it perfectly, Sheila.
Yeah, that's super helpful. And I think even within the region, what is really interesting is, and Eugene, you presented the data about the Maputo site, which had been part of the initial conversations and then didn't go forward because incidence was much lower. And that's a good thing. So if your community doesn't have research, if it's because your incidence is too low to support a large trial like this, that's actually a very good thing. And I think often not well described. I wonder, importantly, I think Julie Patterson asked a question earlier about the data that is forthcoming related to FTAF or Descovy, the brand name, and if the data, how you made the calculations and your hypotheses about potential efficacy, and if the data you all eventually present around FTAF Descovy for PrEP, if that would lead at all to a potential licensure related to FTAF for cisgender women.
So we've been talking with Gilead because obviously they're collecting data in the PURPOSE trial, and I think it's it's interesting because it's obviously possible they may get a result for lenacapavir early, and if they were to do that, I wonder what impact that then means for the other two arms, the Truvada and the Descovy. So I don't know. But we've talked to Alex and Jim about preparing to combine the results. So with PrEPVacc in its own, I don't think we would have enough data for it to support pivotal licensing, so to speak, because it was a second randomization, the person years, and obviously the event rate, and it is going to be difficult. So one of those questions was, how will we manage the communication of the results? So the PrEP trial, I think we've reached the end in person years of the PrEP trial, but it was ongoing at the time of the IDMC, and they recommended we continue. The vaccine trial will go on until the last visits, which will be probably towards the end of May, that kind of time, April, May. And then at that point in time, we should be able to have a result for the vaccine trial, and it will come out first. And as Sheila was explaining, we're going to try and use the data we're collecting in the vaccine trial after the study prep period to help us work on that counterfactual incidence. And at the moment, synthesis, and Sheila would say more about this, I think synthesis is looking challenging, but at the very least, we'll be able to produce a table of the different measures of it, and it will give people a sense of of how good it is. You'll see obviously the difference between the two groups, if there is any difference or if they're the same. And then I think a really difficult question to answer was about the lower bound of the non-inferiority margin. We will do a non-inferiority analysis, I'm sure, but it's not our primary analysis. Our primary one, as Sheila said, is the averted infections ratio. And one of the nice things about that methodology is you get a tighter confidence interval around it. So I think we'll get there.
Fantastic. Thank you for that, Sheena. And for those who don't know, PURPOSE 1 is the trial that Gilead Sciences is sponsoring, as Sheena pointed out, looking at their injectable lenacapavir, but with FTAF for cisgender women. And I think the composite data would hopefully allow FTAF to be used for all populations. I think, Rachel, your data really reflect the value of the smaller pill size relative to TDF or Truvada. So I guess watch this space for the months ahead as data go forward. I do want to come to a question that Esther Nakazi, a fabulous journalist in Uganda, asked about what was the reaction of the trial participants to that news, Eugene, as you presented it at ACASA, and as you all presented that you shared that information with participants in advance. I don't know if you or Kuliswa on the community working group or others on the line from the trial sites want to say a word or two about how this was received and perhaps how the importance of good participatory practice in the whole context of the trial might have helped support those trial result disseminations. Oh, Eugene, you're on mute. Oh.
So sorry, yeah. I
There
was
you go.
saying I wonder if Vincent or someone else at the sites can actually answer this question, because I think Vincent, you've been directly involved in providing this feedback. Are you on?
Sylvia is there.
Sylvia?
Kindly
Yeah.
please,
Oh,
Oh,
Vincent.
there's Vincent.
There's
Oh,
Vincent.
great.
kindly please, let me have the question again. I'm sorry.
The reaction from trial participants and the communities around the sites about the results that were released late last year. How did people respond?
So the update, because we
Yeah.
don't have the trial results as yet, and I must repeat that. So yeah, we gave the update, and the messages were very clear. One, before we gave the messages, we sort of gave an overview of the trial and what the trial objectives were, and then which the Eugene and other people have shared. So we reminded the participants and other stakeholders that the trial was assessing the safety and efficacy of these vaccines. So the answer had to be yes, vaccines are infectious, or no. And we know this was being monitored throughout the trial. So it was an expected outcome. So it was disappointing because people invested in a lot of time and energy and resources, but it was an expected outcome. So disappointing as it is, it wasn't shocking, I should say. Yeah.
Great, Vincent, thank you. And it really speaks to the work that you and the teams did. And we've seen this historically when communities are involved throughout the trial process in a durable way and are part of the process throughout, results can be understood and acted upon. Speaking of understanding and acting upon results, I want to connect two questions in the chat related to the future of vaccine research. One comes from Roger Tattoo, who's asking that the vaccines you were studying were in that category of the non-neutralizing antibody approach, and what the impact of PrEPVacc might have on those approaches overall. And it relates, I think, to Joyce Nganga's from Wacky Health's great question. Will the PrEPVacc team continue and to explore additional vaccine concepts? And if so, what might you be focusing on?
So Mitchell, I don't know if I can, well, that's a week too early. We're meeting next week with all the investigators, and that is absolutely first and foremost in our thoughts. So I don't feel that this group will be giving up at all. I'm heading to retirement. But I think the group is passionate and they will continue on. But we have the investigator meeting next week and there will be more discussions about this. Eugene, what do you think? Will you carry on?
Definitely, yes. We are carrying
There we go. Mitchell, there was one other thing I saw in the chat, a question that made me feel that I had really not done a good job. I should have made it clear that the participants did not know what vaccine they received. That was blinded, but they did know which PrEP they had. They knew the PrEP group they were in. Sorry that I hadn't made that clear in my presentation.
No, super clarification. And on that last point, and I think to both Roger and Joyce's question, it's clear that, and I think there's a message above from Richard Hayes and you said this in the very beginning, Sheena, that not only were you conducting a trial, but you were building a capacity across trial sites, across this network, the integration between social science and clinical research and community engagement and good participatory practice. And I think all of us look forward to, and I know that Stacey Hanna, who directs our research engagement program, is working with you all and colleagues to take the GPP work forward and see how it applies broadly. And also to the question from Roger and Joyce about what this means for the vaccine pipeline. We're at a place where PrEPVacc was the only phase 2b or phase 3 efficacy trial in the field for an HIV vaccine. As it begins to wind down, the whole field is looking much further upstream at concepts. And that's a challenge, I think, for all of us in this field, researchers, product developers, funders, advocates. How do we think about the future of the pipeline? Clearly, the need is still there, but what vaccines to study, and perhaps particularly, Sheena, to your early point, how do we design the studies in the future? Because the future is only going to get more complex. I wonder with that, I know we're just at the top of the hour. I do want to give a chance for all five of you, the four of you on screen, and I think Chris was still there, who mentioned in Virilum the results were disappointing, but well accepted. I wonder if each of you just want to give a quick kind of perspective on what this trial has meant to you as investigators, as community, and also what you think the next most important steps are. So maybe I'll just look at the screen and I'll start with you, Rachel. Key lesson and what it means for the future?
I think from what we are seeing, again, it answers the question of, do we want to continue with vaccine research? Yes, because we see that participants really love sort of vaccine prevention methods that are not in oral sort of pills. So we really need to continue and see where the research takes us. But yeah, we need to continue. But then the other thing that is affecting all of this is the perceived stigma. It's the underlying thing in the non-uptake of all these products. So we need to continue to engage people. And I think the best way is to appeal to the self-evaluation of each person as we come across them, as opposed to giving group information and calling them at risk populations. We need to get to a point where we can appeal to every individual, because like Sheena said, risk is not static. So we need to appeal to people to have a self-evaluation of their risk. Thank you so much.
Thank you. Sheila, maybe I'll turn to you next.
Was that Sheena, not Sheila?
Oh, I said Sheila, because I'm going to come to you, Sheena, in a second, because I want you to respond to
yeah.
Stacey's question as well. But go ahead, Sheila.
Yes, so I think the next important thing is we have several interventions right now that work, that can prevent HIV. So we need the people at the most risk of HIV to know they're at the most risk and they utilize these interventions. Let them march in the streets and demand access to these interventions if need be, and let them be able to find out how do, since they're at the line of, since they're our first line against HIV infection, how do they prevent it? Have they utilized all the resources they have accessible to them as it is? But really empowerment and accessibility to knowledge and more innovativeness in the scientific community. Yeah, thank you.
Fantastic, Sheila. Thank you. Sheena, I will go to you next. And maybe if you can pick up on Stacey's question about what do you think the impact of the results are on the future of these combined approaches, combined trials with PrEP and vaccines?
So that's a difficult one, Stacey. I don't know. I can honestly answer that quickly. I mean, I think this, yeah, I can't answer that quickly, so I'm not actually not going to answer it. But what I wanted to say, I think, was what I certainly learned was that actually there was a huge amount of capacity there already, which I kind of knew. And so I'm not sure really. I mean, we brought some things to the table around design, definitely. I think probably we helped with a bit with that, but there's still a lot of challenges that, you know, Sheila and co are going to have to continue to tackle with the analysis. And then I wanted to pick up on Rachel's point. You know, having worked, really my clinic practice has been mainly with gay men and in a UK setting. But I have had experience in this setting for 20 years now, more than 20 years, starting with the microbicides. And I see that society's moved very slowly, really. It has moved, and that's fantastic. Incidence has gone down, and that's a brilliant thing. As incidence goes down, actually, ironically, it's a bit harder for people to realize there's a risk because they're less likely to know someone who's got HIV. And we're going to have to move society and accept that it moves slowly. And in the meantime, it is probably the best thing we can do biomedically is having mechanisms that people can use privately So I'm really struck by the fact that people live in multiple houses. They don't have the privacy to store the pills. I think this is an issue, and so those private ways of preventing, like vaccines and injectables, do offer something quite important in this space as we make that shift in stigma being reduced in society.
Fantastic. Let me first, Koli, I don't know if you're still on. Any last thoughts from Virilam?
Good evening again. We'll soldier on. We need the research to go ahead. We will never, be disappointed as much as we are disappointed with the preliminary results. However, we still have hope that one day a vaccine will come that will be effective in ensuring that people are not transmitted with HIV.
Koli, thank you. Brilliantly said, and very much in line with what Vincent, you put in the chat from one of the city commissioners with the updates about the need to continue this research. As hard as it is, the commitment and what you just expressed, Koli, is so important. Eugene, you have directed this project. You have managed everything from clinical trials to finding a room to present results at ICASA. Last thoughts from you.
Yeah, thank you so much, Micho, and thank you to AVAC in general for the opportunity to share these results and for the support that you've provided to the PrEPVacc team right from the beginning, including the training. So I think for me, someone asked why in East Africa. So we've been preparing and communities, our communities and training staff and so on for a very long time. I think I've been involved since 2004, really, preparing for vaccine trials. And we know that all the vaccine trials that have happened in Africa, testing efficacy, have been in Southern Africa, I think mostly. So really, PrEPVacc was the first one that included sites from East Africa. We definitely have the HIV problem in East Africa, and as everyone knows. So I think for me, this was really an opportunity for us to eventually tell the communities we can also do this, and this is what we've been preparing for. And I think, like Vincent said, some of the communities we worked with, we've been with these communities for quite some time, and they've been prepared and knew what the different outcomes might be. Having said that, yes, we got disappointing results, but we still have the problem. Sheila alluded to something about people continuing to take PrEP. I think it was Rachel. It is the people who understand that they have risk. And I think that is the biggest problem we have with the current interventions. Somebody must be able to self-evaluate and say, I have risk, and therefore I can benefit from this. If we had a vaccine that prevents HIV, I think this would be a little bit different. It is something that you would recommend probably to your daughters, to your sons, to your friends to go and have, and something that they could easily accept to have, whether they consider themselves to be at risk at that time or not. So I think we really must continue to work at this, and I'm hopeful that one day, like my colleague in South Africa said, we'll finally get a solution for this and get a vaccine that works so much.
Fantastic. Eugene and the whole PrEPVacc team, thank you. And so grateful that you have been able to present all of this. There's still more to come in terms of data, in terms of capacity and the future. And we look forward to working with you always. I think from an AVAC perspective, just to say where we began 30 years ago saying the world needed an HIV vaccine hasn't changed one bit. The need is still there. And to Sheila's great point, it is important that we deliver the things we have, even while we maintain a research agenda for the things we still need. And so PrEPVacc for us was very much that trial that brings together so much of our agendas of delivering PrEP and of developing a vaccine. And that doesn't change because of the result at all. That commitment, that need is still there. And it also relates to how AVAC began to transition to look at some of these broader issues. And it was really around the controversies of the earliest PrEP trials now 20 years ago in developing the good participatory practice guidelines. So we're grateful to have been able to be along for your journey and support it from the margins, because PrEP and vaccines and good participatory practices at the center of it all have been what we're committed to at AVAC, and we look forward to working with all of you in the PrEPVacc team, in the sites, in the communities, and advocates all in moving this agenda forward. Thank you very much. It's a great start to the new year to be able to dig in deep and to lay out work that we need to do going forward together. So thank you all. Have wonderful evenings, safe evenings, afternoons, and mornings for those still early in the US West Coast. Thanks so much, and we will definitely keep these conversations going throughout the year.
Thank you, AVAC.
Thank you, AVAC.
Cheers off.
Thank you. Bye.
Thanks. Bye.
Hey, oh, Rachel, it's okay. Bring him back. That's the next generation. Thank you all. Take good care. Cheers.